started by Dr. Renu, and I'll just continue with the leftover two, and others I'll just describe because that's a topic in detail in itself. So these are infections which are major cause of maternal and fetal morbidity, and it is because there is a unique maternal and fetal vascular interface which may protect fetus against infectious agents, and at times it provides a conduit for transmission. Disease outcome always depends upon maternal serological status, acquisition mode, gestational age at the time of infection, which is worst outcome in the first trimester, except for HSV. So for all the diseases, universally think if they are acquired in the first trimester, the baby is undergoing organogenesis, and that is the time it is worse, except HSV, and immunological status of the fetus and the mother. So epidemiology, that is approximately 2 to 3% of all congenital anomalies are attributed to perinatal infections. Initial evidence of infection may be seen during the intrauterine period, maybe at birth, in infancy, or maybe not even until years later. Intrauterine manifestations of congenital infections include abnormal growth parameters or developmental abnormalities. And infected newborn infants may show abnormal growth, developmental abnormalities, or multiple clinical and lab abnormalities. So this was the description of TORCH infection. TORCH starts with toxoplasmosis. Others we were forgetting: rubella, cytomegalo, and herpes. Others could be syphilis, treponema, hepatitis V, HIV, parvovirus, varicella, and now they are including Zika virus and malaria also. So any viral infection which causes a congenital infection is labeled as others. So the risk factors would be bacterial also. Any causes congenital infections, right? So maternal risk factors which predispose her are lapsed immunization, sexually transmitted diseases, animal exposure during pregnancy. So that there will be the transmission could be at the time of intrauterine, intrapartum, or neonatal, and these are the various description. Viruses is varicella zoster, coxsackie, rubella, CMV, parvo. So all those which we are not talking about are others then. So HIV, Zika, SARS, CoV-2, bacterial would be Listeria, syphilis, and Borrelia. Protozoa would be toxoplasmosis and malaria. Ascending infections could be bacterial, that is group B, Streptococcus, coliforms, and virus again at B, HIV. Intrapartum also there is a long list, and neonatal also there would be human transmission could be from Staphylococcus, HSV, influenza, SARS, and CoV-2. SARS also comes over here. So respirators and catheters, Staphylococcus coliformis. So this is a long list, but this is very important. So this is another representation of a similar thing. So sorry ma'am, you wanted that? I'll give you ma'am. So transmission of infection could be horizontal or vertical, has been described. Horizontal is spread from one individual to other. Vertical is passage from mother to fetus via placenta during labor or delivery. There's another term which is secondary attack rate. That is probability of infection developing in a susceptible individual after contact with a infected person. So every disease has a specific secondary attack rate. And fetal and neonate immunity. Fetus and neonate have compromised active immunological capacity vis-a-vis older children and adults, according to McGovern. So at 9 to 15 weeks of gestation, innate and adaptive immunity develop. Primary fetal response is in innate immunity by macrophages and dendritic cells. Lesser extent by adaptive, that is B and T cells. Passive immunity the baby gets from maternal immunoglobulins starting at 16 weeks, and at 26 weeks, fetal and maternal concentrations are equal. So that's most important for us to remember. Fetal cell-mediated immunity is primed by maternal vaccination. So that is the reason why we need to vaccinate the mothers, independent of passive immunity. So even baby's immunity is being primed by the maternal vaccination. So neonatal response to infection, they do not present with classical clinical presentation. After in utero infection, the uterus may be jittery, lethargic, unusually depressed or acidotic, may suck poorly or vomit, may have RDS, hypothermia or not hyperthermia, depressed TLC, and neutrophils are usually seen. So I'll be talking about toxoplasmosis. It's a protozoal infection caused by Toxoplasma gondii. Most maternal infections are subclinical or asymptomatic or present with mild fever, malaise, and lymphadenopathy. Pre-pregnancy infections confers immunity and thus prevents a vertical transmission. And immunocompromised have severe infection and reactivation may cause encephalitis, chorioretinitis, or mass lesions in the fetus. Routes of transmission are eating raw or undercooked meat infected with tissue cysts, ingesting soil or water contaminated with oocytes from cat feces. So incidence global is 0.6 to 1.1%, and in India it is 1.43%. And the risk of maternal fetal transmission is highest in the first trimester, but in early pregnancy, the transmission risk is low, but sequelae is worst for toxoplasmosis. This is according to American College. And in less than 13 weeks, the risk of transmission is 5 to 15%, but fetal abnormality is to the tune of 60 to 80%. In second trimester, around 25 to 40%, but fetal abnormality chances reduced to 15 to 25%. In third trimester, fetal abnormality decreases to the tune of 5 to 10%, and greater than 36 weeks, it's only 2 to 10%. So neonatal, most infected fetuses are born without obvious stigmata, clinically present with generalized low birth weight, hepatosplenomegaly, jaundice, and anemia. Some have neurological disease with intracranial calcification, hydrocephaly or microcephaly. Many later develop chorioretinitis and exhibit learning disabilities. So the toxoplasmosis has a classic triad of chorioretinitis, intracranial calcification, and a hydrocephalus. And this may be accompanied by convulsions. Infected neonates with clinical signs are at a greater risk for long-term complications. The screening in pregnancy is the same as has been described by Dr. Renu, that investigation of antibodies of toxoplasmoma, IgG develops around 2 to 3 weeks and peak at 1 to 2 months and may persist for life, often in high titers. IgM appear by 10 days after infection, become negative in 3 to 4 months, and at times detectable for years. So IgM alone is not used for diagnosis. So we do an IgG assay. If it is IgG positive, then we do an IgM assay. If IgM assay is positive, then if we have to, it means a current infection. But if we have to estimate the time of infection, we do an avidity. And IgG negative, advise women to take precautions to avoid infection. IgM negative, reassure there is no risk to the pregnancy. But we have to see that we are testing this IgM after 6 months of pregnancy. So she could have been infected in the earlier phase. So you have to, if testing after 6 months of pregnancy, confirm from an earlier sample if it is present. So IgG avidity, high levels means immunity is there. Acute infection was before 3 to 5 months. But lower intermediate levels, they have a question mark of recent infection. We have always to confirm by the rising levels of IgG antibodies, not the avidity again. So we do IgG antibodies after, if the levels are increasing, then infection has been acquired in the recent 2 to 3 months of the first testing. And if the levels are stable, infection acquired before 2 to 3 months. So management is according to the gestational age. A sequelae of congenital toxoplasmosis is severe in early gestation. So confirmation of infection could be by ultrasound also. We can find a hydrocephalus, intracranial or hepatic calcification, ascites, placental thickening, hyperechoic bowel, or FGR. If all these are found, then we can suspect toxoplasma and CMV infection as was described earlier. We confirm by PCR testing of the amniotic fluid in such cases. Diagnostic amniocentesis and PCR for both toxo and CMV is done. Maternal serologic testing is also done for the both, and sensitivity of toxoplasma detection in PCR varies with the gestational age and is lowest at less than 18 weeks. So we have to go above 18 weeks for its sensitivity to increase. So management, if it is less than 18 weeks, spiral spiramycin, but spiramycin does not cross the placenta, right? So spiramycin, to reduce, we are reducing the vertical transmission, we are reducing the maternal load and vertical transmission. And AFPCR is to be done. Then this is the follow-up after 18 weeks, and fetal ultrasound 4 weeks until delivery. An infection acquired greater than 18 weeks, then pyrimethamine and sulfadiazine plus folinic acid, because it crosses the placenta and it's for both the mother and the baby. And the follow-up is the same, AFPCR greater than 18 weeks and fetal ultrasound. And we can continue spiramycin until delivery. And in the cases of pyrimethamine, if the patient is not tolerating it, we can switch over to spiramycin. Evidence is weak to say that early treatment can reduce congenital toxoplasmosis, but treatment is definitely associated with the reduced rate of serious neurological sequelae and neonatal demise. So we can say that congenital toxoplasmosis totally will be eliminated? No. The serious side effects would be reduced. So for oral dosage forms, this is the dosage which is given, that 1 to 2 grams 2 times a day, or 500 milligrams to 1 gram 3 times a day. For severe infection, the dose is 2 to 2.5 grams 2 times a day. For children weighing 20 kilograms and above, up to 20 kilograms, it is based on the body weight. The usual dose is 25 milligrams per kilogram of body weight 2 times a day, because it was copied from the British literature. That's why it's given in pounds as well. So neonatal management would be symptomatic congenital toxoplasmosis, may be presenting as chorioretinitis, retinal scarring, intracranial. There's a lot of long list, and this is documented by IgM or PCR positive with abnormal placenta can always be there, and documented by IgM or PCR positive with serum IgG levels considerably higher than the mother. So the treatment was again that 25 milligrams per ml, or it is given for around 12 months, and we repeat IgG for the baby at 6 months. So prevention is no vaccine is available. Preventive strategies would be cooking meat to safe temperature, peeling or thorough washing of fruits and vegetables, cleaning all food preparation surfaces and utensils in contact with raw veggies, fruits and vegetables, wear gloves while handling cat and cat litter, and keep cat indoors. So now we come on to herpes simplex, another disease which is causing lots and lots of morbidity to the baby. It's a lifelong infection, may be inactive for periods at time. There are 2 types of herpes viruses based on immunological differences. The 2 have significant DNA homology, that is similarity. So infection with other will give a cross protection with the other. So HSV1 is primarily a non-genital one. It is usually acquired in childhood, and its incidence is reduced due to better hygienic conditions, and more adults thus the more adults are prone to HSV2. HSV2 is an STD that causes genital herpes but can also cause oral herpes. So transmission to the mother is by sexual contact, to the fetus is via ascending infection in utero or exposure during parturition. Fetus is exposed to virus from the lower genital tract. HSV1 or 2 invades the uterus following membranes rupture or is transmitted by contact at delivery. But rare cases of maternal endometritis also occur. Maternal primary infection during 3rd trimester has the highest percentage. So this was the only infection which is worst in the 3rd trimester. All the others are worst in the 1st trimester, and around 30 to 50% and of neonatal infection, it's lowest in the 1st trimester, that is less than 1%. Secondary reactivation of HSV is 10 to 30 times less likely to result in transmission to the infant because antibodies were already present. Seroprevalence of HSV2 was 21% and HSV1 was 59%. But seronegative pregnant women have a 4 to 5% risk to acquire either serotype during pregnancy. So if she is seronegative, she can acquire any. But if she is seropositive to one, the other would definitely be lower. For those who are already HSV1 positive, acquisition of HSV2 is only 2%. So risk of transmission, risk of neonatal infection correlates with presence of HSV in genital tract, the type of HSV, invasive OPS procedure, stage of maternal infection, primary or recurrent, maternal immune response, duration of ruptured membranes, mode of delivery. Most infected newborns are born to mothers with no reported history of HSV. So this is very important to note that we have to really examine the baby for any stigmata. The postmortem transmission, which is very uncommon, it's passed to newborn by contact with an infected mother, family member, or healthcare worker. The clinical presentation is just like a peripartum transmission. So progression of HSV is once transmitted, virus replicates at the entry site. Following mucocutaneous infection, the virus moves in a retrograde manner along the sensory nerves to local ganglia. It remains latent for life in cranial nerves or dorsal spine ganglia, but can reactivate and cause recurrences. Asymptomatic virus shedding occurs every 1 to 3 weeks after 1 to 3 weeks after primary infection, and this is the most dangerous period when the patient gets infected. So types of HSV infection could be first episode as a primary infection. First episode could be a non-primary infection also. Recurrent disease or asymptomatic disease. First episode as primary is in this HSV 1 or 2 is isolated from the lesion, but there is no serologic antibodies. Incubation period is 6 to 8 days. It's followed by papular eruption with itching and tingling. There will be multiple vulvar and perineal lesions which ulcerate around to 1 to 2 mm in size. Also can be associated with inguinal adenopathy, which may be severe. Cervical involvement is common. Viremia can present with transient systemic influenza-like symptoms or isolated high fever with or without painful lesions. Few women require hospitalization for febrile syndrome or for pain control of widespread ulceration. Hepatitis, encephalitis, pneumonia, although unfrequent but not unseen. Disseminated disease is rare. After 2 to 4 weeks, all signs and symptoms disappear. Asymptomatic primary HSV2 genital infection may reach up to 90%. So that is the most important. It is asymptomatic, but it can be transmitted. First episode of non-primary, when one HSV type is isolated from the lesion, but the serological antibodies are for the other type. A prior childhood HSV1 infection likely provides cross-reacting antibodies to blunt the effect of HSV2. Compared with primary, this will be milder. The lesions are less painful, briefer duration of lesions, and viral shedding. Then recurrent disease, isolation of HSV 1 or 2 from the genital tract of women who carry the antibodies to the same serotype. In latency period, viral particles reside in nerve ganglia, are reactivated mediated through poorly understood stimuli, present with fewer lesions in number, and are less tender, and shed virus for a shorter period than those of primary. Typically, they recur at the same site. Recurrences are more frequent in the first year after initial infection, and then the rates decline. Gravidas with known prior history of genital HSV often experience recurrences. Asymptomatic viral shedding is defined by the absence of clinical findings. Most infected women shed virus intermittently. Most HSV transmission to a partner occurs during these periods of asymptomatic shedding. So diagnosis is for women with either suspicious ulcers or sonographic findings suggestive of congenital infection. Direct virological testing is recommended. Routine testing is not recommended. Direct virological test could be PCR or culture, either from mucocutaneous lesions or by amniocentesis. For mucocutaneous lesions, sensitivity of culture for detecting HSV is low. As vesicular lesions, they crust and heal, so you would not get any virus from there. Sometimes the results are not available for 7 to 14 days. Negative culture or PCR does not exclude diagnosis, but false positive is rare. So if it is positive, then definitely the patient has the infection. For amniotic fluid assessment for both culture and PCR are recommended. So interpretation, serological assays detect antibodies produced by HSV glycoproteins G1 and G2. These proteins evoke type-specific antibody responses to HSV 1 and 2 infection respectively, and they are different. Differentiate the two serotypes. IgG antibodies develop 1 to 2 weeks after primary infection and then persist. Sensitivity and specificity of glycoproteins-based IgG is 90 to 100%. Antibody detection confirms clinical infection in primary or non-primary. In very early primary, maybe serology is negative. In asymptomatic patient, it may reflect a carrier state. So best is direct detection of virus from the lesion with concomitant type-specific serological testing. So serological testing also helps when recurrent genital infection or atypical symptoms with negative HSV PCR culture are seen and patients whose partners are positive with genital herpes. So role of ultrasound, it detects hydranencephaly, microcephaly, intracranial calcification, ventriculomegaly, non-immune hydrops, liver calcifications, early or severe fetal growth restriction. So something about fetus and neonate, HSV presents due to perinatal exposure and clinical manifestation present 10 to 21 days after infection. So that is the reason why we have to test the mother after 21 days of any infection, all present with fever in the neonatal period, but transplacentally acquired, see we are talking of transplacentally acquired infection, but transplacentally acquired antibodies also prevent disseminated disease but they do not prevent a local infection in a neonate. So effect on the fetus could be miscarriage, stillbirth, congenital malformations, including CNS, skin and eyes, preterm birth, PPROM, and intranatal transmission, most common in second stage and affects eyes, upper respiratory tract, and umbilical cord. Risk is markedly reduced by doing a cesarean section. So neonatal herpes, there are three major clinical manifestations: skin, eye, mucous membrane, that is SEM disease, which presents as rash, normally vesicular and often noted in areas of trauma, such as fetal scalp electrodes or the use of forceps in delivery, seen in 40% of the cases. CNS symptoms seen in 30% could be presenting with encephalitis, lethargies or seizures, hydranencephaly, microcephaly, intracranial calcification. Disseminated disease, again seen in around 32%, presents earliest after approximately 1 week of age as sepsis-like syndrome with skin lesions to include vesicles, hypotension, hepatosplenomegaly, and lethargy. We can expect because it is a disseminated disease. So in such a case, we have to evaluate the neonate. Neonate with concern for HSV should be aggressively evaluated by complete sepsis evaluation, including lumbar puncture, swabs from mouth, nasopharynx, conjunctiva, and anus, taken for HSV culture and PCR. If skin vesicles present, they should be unroofed and sent for culture and PCR. CSF and whole blood sent for HSV culture and PCR. Liver transaminases are early clue for disseminated disease. Further evaluation may depend on type of infection the child has and can include consultation with ophthalmology, neurology, and audiology. Hearing tests must be conducted as they may help with decision making regards to treatment. So the management, oral antiviral medication for HSV in pregnancy, acyclovir and valacyclovir. The doses would be 400 milligram TDS for 7 to 10 days, or valacyclovir is 1 gram BD for 7 to 10 days. Symptomatic recurrent infection, that is episodic therapy, acyclovir 800 BD for 5 days, or 800 TDS for 2 days, or valacyclovir 500 BD for 3 or 1 gram for 5 days. Daily suppression, if required, is acyclovir 400 milligram TDS from 36 weeks to delivery, and valacyclovir is 500 BD from 36 weeks to delivery. Oral and parenteral antiviral preparation attenuate clinical infection and viral shedding duration. HIV patients require a longer therapy. Chronic suppressive therapy limits recurrences and reduce heterosexual transmission. In pregnancy, acyclovir and valacyclovir are safe. Famciclovir safety data is limited. So in disseminated infection, we have to give intravenous. Acyclovir is 5 to 10 milligrams per kilogram every 8 hours, or for 2 to 7 days, followed by oral therapy completing 10 days, or maybe longer when the patient is immunocompromised. For intense discomfort, local analgesic and topical lidocaine. For urinary retention, we can give a indwelling bladder catheter. And recurrent HSV in pregnancy, antiviral genital lesion, but no transvaginal procedures are required, but avoid transcervical procedures. So suppressive therapy, as I said, begins at greater than 36 weeks of pregnancy and continues till delivery. With clinical history of genital herpes, atypical neonatal symptoms or herpes infections have been reported in spite of maternal suppressive therapy. So we can't sit on our laurels that we have treated the woman, the baby would be saved. The baby still can present with atypical presentations. So delivery, vaginal delivery, when no prodromal symptoms or local lesions on vulva, vagina, cervix, we can go easily for a vaginal delivery. Invasive fetal monitoring also is permitted in such cases. Cesarean delivery, when prodromal symptoms or active genital lesions are present, no specific duration from rupture of membranes has been described when the fetus will not benefit from cesarean delivery. We cannot say now she has come to us after 8 hours of ruptured membranes, koi फायदा नहीं cesarean करने का, already exposed, but still we can save the fetus in doing a delivery, our cesarean delivery. In emergency, if the patient has come fully dilated and she's about to deliver, we can apply occlusive dressings can be applied to active anogenital lesions to decrease the exposure. Neonatal treatment, acyclovir can be considered when mother gets infected at term, and doses 20 milligrams per kilogram IV every 8 hours for 14 days if the disease is limited to skin and mucous membrane, for 21 days if it is disseminated or CNS involvement is there. Breastfeeding, when women with active HSV lesions may breastfeed if breast skin has no lesions. Strict hand washing is essential. Valacyclovir and acyclovir may be used for symptomatic maternal lesions during breastfeeding as drug concentration in breast milks are low. Thank you.